Okay. Eileen, Grace, Yunho, Eugene, Dean, long time no see.
Hi, good morning, Dr. Chae.
Good morning. And I guess Sungmi is here. Sungmi, you can change your name. Okay. All right. Should we start with let's see. Who has to leave first?
So I actually have class in about an hour, but I heard back from Dr. Bhumika about just a couple days ago about her manuscript and thinking about submitting for this World Congress of Immuno-Oncology, which is due later in March, because we're working on the case report. So she had asked me if I can review the manuscript with you, and also this abstract that we worked on together, because it wouldn't be eligible for ASCO because it is a case report, but thinking about this other conference later on in March.
Is it lung cancer?
Yeah.
Okay. Yeah, tell me about it.
Okay. Would it be possible to share my screen or? Okay.
Yeah, you can share your screen. All right, Dina, are you graduating this year or?
Yeah, I'm graduating. Yeah, so I'm graduating at the end of June this year, but yeah, I'll be working full time starting in October with this consulting firm in Chicago. But I know they kind of specialize in healthcare type work, so should be pretty interesting, I think.
What kind of work is it?
It's more like general management consulting. So at least the Chicago office, they specialize, one team specializes in healthcare and another team specializes in like construction or something, but similar, I guess, approach to work.
Good. Congratulations.
Thank you.
What is your big plan? Are you gonna be in consulting business for a while or?
Yeah, to be honest, I'm still trying to figure out. I think definitely at least for a year or two. But yeah, I know they have a lot of opportunities related to healthcare, whether that's kind of going further in healthcare or even going to medical school, things like that. So.
But are you still? But you're considering medical school? Still?
Yeah, I think. Yeah, just want to take some time to figure out, and at least be working in between.
I see. Yeah, good. No, I think it would be great to have that kind of experience, and it will just give you a very different perspective.
Yeah, for sure.
Yeah, consulting.
Yeah.
Yeah, but I don't know. I mean, you'll be really busy if you start working, but I feel like learning and writing and publishing has to carry on. I mean, it's the vital piece.
Yeah.
Any luck talking to Elena or Pedro?
Yeah, so I mean, I reached out a couple times, I think, since we had the connection with Ben. And I think Pedro sent one email, but then after that, still hasn't been able to get in touch. Yeah, so I updated Ben through email about kind of where the projects left off and kind of the challenges that we're having in reaching them. So I'm not sure, like, if.
But you have the most recent
Yeah, so I sent him my most recent manuscripts and kind of filled him in on what are the pieces of data that were missing. Because I know with the Elena's project, we were waiting on the statistician for an updated figure. And then for Pedro's, we were waiting on something confirming the patient data so we can fill in the rest of the tables. And so I was able to send him those and include the versions with my most recent comments.
Okay.
But yeah, at least accessing the patient data, I'm not sure if that's maybe something he is able to do. So I kind of let him know the remaining information that we would need, but not really sure how to go about accessing that from his side, if that's possible at all.
No, he can access patient information, no issues. But yeah, just keep following
Okay.
where things are. CC me and just make sure
Yeah.
it moves forward.
Yeah.
And you or Ben can come to this
Work on it.
meeting, present, and
Yeah.
I give you edit. That's how we move on. Okay. Yeah. Just be persistent. I know.
Yeah.
Every project in your life will be like this. Someone is working
Yeah.
on it, but they have other priorities, and if you don't make it your priority, it's just always going to be like, oh, I'll do it when someone else get back to you, and that person probably have other priorities. So.
Yeah. Do you know if Dr. Elena, is she working at a different hospital now? I think because that's what our concern was about her Northwestern Medicine email. But I know she was interviewing last year.
Yeah, I do have her email, new email.
Okay.
Yeah, I'll give it to you.
Okay, thank you.
But yeah, show me what you've done.
So are you able to see my screen?
Yes.
Okay. Yeah, so this is the case report that I've been working on with Dr. Bhumika. And so we've put together the full manuscript, and I just most recently left a round of kind of edits. But basically, this is a patient who, with lung cancer, and the Garden report kind of showed persistently high levels of IDH2 mutation. And so that's when erdafitinib was added off label. But then I think 6 weeks after that, they had progressing differentiation syndrome. So we couldn't really make a lot of conclusions, but I think a lot of what we wrote about was just kind of the background and how there might be kind of branching mutations related to IDH2 as well as other kind of common mutations. So if possible, could we just kind of go through it for kind of more minor edits and stuff?
The link.
Okay. This is a Word document version, but I can.
Oh, this is the word.
Yeah, but
leave it. Just
okay.
So for those of you who do not know this project, let me review. So differentiation syndrome, most of you are familiar with this in setting of leukemia. And it's commonly seen in acute myelocytic leukemia. It's the M3 type. And the point of this report is that differentiation syndrome seen in leukemia world was seen in non-small cell lung cancer. And in this patient, IDH2 mutation was found, and IDH2 inhibitor, which is erdafitinib, was used off-label experimental use. So retinoic acid syndrome is another word for differentiation syndrome. And uh, if you get it, these are the symptoms that you have: fever, respiratory distress, hypertension, um, pleural pericardial effusion, weight gain. And these were the symptoms that my patient exhibited. So usually differentiating agents such as ATRA or arsenic trioxide can cause these symptoms. Um, but what's interesting is that ensinomib, approved for AML treatment, when used in other tumor types, such as non-small cell lung cancer, can still cause this differentiation syndrome. Um, and it has been reported in leukemia. This is the first time we're reporting in non-small cell lung cancer. Go down. So this was 54-year-old and presented with these symptoms I just told you about. And um, okay. So here there's like NGS and biomarker testing. So I think this is redundant. You could just say what was found. Um,
Okay, so we don't have to say it was sent. We just say through an NGS we found this.
yeah.
Okay.
And PDF was not detected by
Should I scroll down?
Garden Health City. Yeah. So Eugene O, and this is relevant for your abstract too. Whenever you um, so circulating tumor DNA assay uh, is Garden 360 here. So I would say take out using and put Garden 360 in the parenthesis and just put comma there. Yeah.
Yeah. Okay.
So there's a product name and then the company name and the headquarter location. That's how you put the actual specific essay. You don't have to mention the commercial name. You just use the
Yeah.
term and then define what that is in the parentheses. So, that's how you same thing with Lee, where you can have Veristrat. Don't use Veristrat. It's a proteomic signature when in the abstract.
Okay.
Reveal the presence of fusion at the frequency, fusion at the VAF. Variant allele frequency. I would put variant allele frequency at at
And,
at yeah at and then at
and the
BAF, yeah.
okay.
Then following you use BAF. Yeah. Go down. It's an off-label targeted treatment. So let's take out the word off-label. We know it's off-label, but I think the word experimental
Okay.
is better. So and synonym should be small, not capital.
Okay, I'll go back through and correct those.
Yeah. So this is same for all of you guys.
Yeah.
Generic name should not be in capital letter. And commercial name, commercial drug name should not be used in the abstract. Okay. And IDH2, any gene name should be italicized. Protein
Yep.
Is always in small letters and never capitalized. Okay. But the acronyms can be capital, like PDL1 is actually protein. The PDL1 gene is italicized. Okay, so IDH2 should all be italicized. There are rules. When you say resist, put the resist criteria.
Sorry.
The
Okay.
So there's echo ejection fraction here, but is there a comparison?
For the resist criteria.
Echocardiogram, ejection fraction. So I'm not sure.
Yeah, I'm not too sure about it, but I can ask
Yeah.
Dr. Boone.
Yeah. So the question is, was there a drop in? You know, it only makes sense if there was a drop or if there was some abnormality, and then whether this is a recovery or not, that's not the question. So if ejection fraction was not affected before, this should come out. So I think you should say how many days of insulin was given, or what was the. So there's a 6 to 8.
Yeah, so I mean, yeah, I'm not sure why we put that time frame as opposed to the number of days.
Also,
but
week is okay, but
Okay.
it has to be. I mean, sometimes it's not clear, but sometimes. So the way in the epic, the way to look. And I know I don't think Bumi has access to the patient's chart anymore. So maybe work with Sumi, Dr. Yoon.
Okay.
So yeah, give Dean your contact information so that you guys can talk. So and so then you could go to Epic in the medication tab you can see when it was actually prescribed and go to the notes in the similar time frame, and usually after ordering it, within a week, it gets to the patient's house. So with that, I think you have to write either 6 weeks or 8 weeks. You can't write 6 to 8 weeks.
Okay.
And then also, yes, there is a progression of disease. No. There's a new pleural effusion, pneumonitis, but also in that 6 to 8 week time frame, what happened to the tumor? Did the tumor grow larger? Or was the tumor stable? So you have to mention it.
Okay.
The reason why we initially thought it was progression of disease is that sometimes pleural effusion could be malignant, and just the fact that pleural effusion is getting worse means disease progression. But in this case, it wasn't, and I think we tapped that pleural effusion and probably found that there was no floating malignant cancer cells.
Okay.
And that's one of the supporting evidence that pleural effusion is a drug toxicity called differentiation syndrome and not cancer. So I think you have to talk about that either pleural effusion or pericardial effusion cap, and then what the cytology showed. And that's the vital. This one paragraph, actually, this is all you need. Like, you don't have to say, alectinib, loretinib, because that's not the point of this. However, for actual manuscripts, it's okay to leave it, but the IDH2 piece is the main. And,
Yeah.
okay.
I think she wanted to show that it, out of all the mutations detected, that's the one that stayed high over time. Yeah.
Okay.
Yeah. So I was gonna ask Dr. Bloom about this because there's some places where we kind of, I think she's like used the same phrasing as earlier, so I was gonna just talk to her about that.
Yeah, rephrase it or.
Yeah, or that might
I would
then make us adjust the. Sorry.
So there's a reference here, 2 and 5.
Yeah.
I don't know where that is, but what I would say is maybe to summarize the pivotal trials results. That was it summarized?
Yeah. So at least this one paragraph is just kind of a restating of the intro, but then we talk about a couple of different sort of relevant studies. So that's would start in this next paragraph, I think.
Go down. Another study. And yes. Okay, go down. I use inhibitors. Go down. AML. No. Okay, go up. So none of the discussion describes why an acidemia was approved. So what you can do is read these reference 2 and 5 and figure out what was the main data that led to an acidemia approval in AML. What was the response rate? What was the projection to survival? What was the overall survival? And what was the primary endpoint? of the trial. And it should all be explicitly described in the abstract.
Okay.
Okay. So write it out rather than just sort of prove. Right. Write out the pivotal trials data.
Yeah. Okay. And I
Uh,
think the concern was that if the other trials that we talked about are relevant, because I know there were some situations in the past where we came across specifically IDH1 only, and we kind of ruled that out. But at least some of the ones we talked about are both IDH1 and 2. But yeah, I think we ended up adding in, one that talks about solid tumors, one that talks about this kind of branching kind of mutation. Yeah, but I guess are all of them still relevant to the discussion? I guess once that basis of IDH2 is talked about, like why would have enicetinib would have been approved in the first place? Because I'm not sure that any of them specifically are using enicetinib, but they're just looking, or at least in the other trial, they're looking at an IDH1 and 2 inhibitor.
yeah. So all the data is coming. Well, I mean, the approval is in liquid malignancy, and we're trying to see what are the data in solid tumors.
Yeah.
So that's the flow of the discussion. But where it starts is how did it first get its approval,
Okay.
right? So you that should be listed here. And then you talk about lung cancer. The main targetability is still unclear. So we say IDH2. What is IDH2? And you describe what it is here, up and down. And in lung cancer, what does it really mean? Go down. In the bioportal, go up.
Sorry.
Right here. Yeah. Alteration. Overexpression was ID noted in tumor cells. Go down. So maybe just, I know you said over 1,000 lung cancers. So this comprehensive study, where is the reference?
I think Dr. Boom is also working on like putting together the references in a note. So I can check with her on that one too.
Yeah, this comprehensive study, we need a reference. So when you say significantly greater for disease outcome, this is not enough. You have to say, compared to this PFS versus this, what was the p-value? This is a discussion where we're actually talking about numbers. You can't just say they did better.
Yeah.
Vague, okay?
Yeah.
Let's go down. IDH2 mutations more prominent in certain subclonal mutations. Uh, so now we have to think about what is the role of IDH2. So I think we have like described the reference number 7 study more in detail, like with the numbers and what was the subclonality, like what was the percentage and um, you know, co-mutation percentage and all that. But this paragraph has to end with the conclusion that while it's not the main, like a truncal or the clonal mutation, which usually found as a subclonal mutation, which is more consistent with a okay, we speculate IDH1 could play a role as a mutation responsible for acquired resistance. I think you can't say for sure, so speculate or you know the fact that usually subclonal um, makes me think that this is likely to play a role in acquired resistance.
Yeah.
Something like that.
Okay.
Not just say it's subclonal. That's it.
Yeah, because after this trunk mutation, it acquires other like evolutionary mutations such as IDH2.
Yeah, just think about a better sentence. That's
Yeah.
next paragraph, distribution clinical trials, including two inhibitors. So vorasidenib is also generic. So
Yes.
it's a dual inhibitor, and it worked in glioma. The last and no indication of antitumor activity was observed.
So I think the paper makes a distinction between enhancing versus non-enhancing glioma. So that's one observation that they had, that it only works in, or it only showed response in non-enhancing stage or type of glioma. But I guess if that's not relevant, I can just try to connect it back to, that it shows like promising initial results in solid tumors or something like that.
It seems a little bit more too specific, a little bit too specific. It's okay for now. So here you have defined as according to Rano. So you don't have to write complete partial or minor response here. So you could say, you talked about the study. The study used Rano criteria to define objective response. That's it. In a separate sentence, and then you,
Okay.
yeah. And declining tumor volume, is that okay? Imaging of declining tumor lesion volume. I don't know if that's suitable.
Or I can say of tumor lesion volume indicated that it was declining
I mean, tumor shrinkage is
Yeah, it's just kind of same thing. Yeah.
the same thing. Volumetric imaging of tumor lesion volume. I mean, I think you take out the volume. Okay. Next, exploring the benefit of IC inhibitor. So here we say we hypothesize circulating tumor DNA has shown that while molecular response for other medications improves, the quality is doing time following the instruction for clinical improvement. However, this is limited by. So I think we didn't write this this is in the discussion, but did we write that in the result?
I'm not
Improvement?
sure. Yeah, the clinical improvement part. Excuse me.
That has to be
Yeah, I can check.
back in the main case report. And I don't know, it could be the patient has increased energy level, better appetite. I don't know. We have to go back to the patient notes at that time to figure out what that means. But obviously, write that in the description. And I don't think we have, so double check to see if there is a CTD, if there's a ctDNA. And I think, yeah, Sydney, you should check it. ctDNA, after we started instrument and see if the ICH2 clone has dropped.
Yes. So I think our issue was with the Guardian report, because we have a figure later on that's kind of the borrowed. But these time points are relative to the start of the first biopsy. And so I think our conclusion was that we don't have another Guardian report after anicitidine was started. Originally, I think we got the dates mixed up. So we thought that, oh, it led to a decrease in IDH2 percentage from like 24 to around 19. But we realized that some of the dates were messed up. So
So when was the drug used? At what month?
I believe the most recent report was a February report, and then the drug was started in March of that year, and then about 6 to 8 weeks after, so sometime in May, then it was stopped. So we don't have a Guardian scan for that. I think because, or based on my understanding, because the differentiation syndrome kind of onset was pretty quick. So there wasn't another sequencing done at that time.
So write that in the discussion. We do not have circulating tumor DNA assay done after the start of experiment, which can help us understand molecular response to the drug. Because the drug was prematurely discontinued, we decided that not to repeat gardens in such in a short
Okay. Yeah. Okay. then we have this last short paragraph. So I think we do the treatment duration of enasidenib was 53 days, so it stopped
Oh, okay.
after 53 days.
After 50 days. So right out, it's in the
In the previous section, yeah.
Also, what's important is, it's this clinical improvement, but also we have to mention what happened to the tumor size
Yeah.
in that short period of time.
Okay.
When patient was exposed to the drug. The other thing that's missing is tapering. It says differentiation was tapering dose of steroid and immediately after extending agents. So what happened to our patient? Go back up.
To the results section.
Uh-huh. High dose of dexamethasone. So I would be more specific. What was the dose of dexamethasone and how long was it tapered off? Like how many weeks? And there was a pericardial window. So that's a surgery, okay? And you open the pericardium and drain. So what was the result of it? And what did it show? Was it pus? Was it, what did it contain? The fluid. And then what was the clinical trajectory? Like after dexamethasone, did the fluid actually eventually disappear? Did the patient breathe better? What happened clinically and how fast did the recovery happen? You know what I mean?
Yeah.
And that's the whole purpose of this abstract, and it's just really not written. So that part's missing.
Okay.
So same thing. What does the literature say about AML differentiation syndrome? When you use dexamethasone, how fast do they recover? Do all 100% recover, or only 70% recover? Or what's the mortality? Right? What's the effectiveness of steroid therapy? What happens if the steroid does not work? What do you do next? These are all good questions, and you need to discuss them in the discussion. Okay.
Yeah, that makes sense.
Okay. So Sunmi, you should help Dean, okay? All right, go to the last paragraph.
Um,
So there's a delayed occurrence of DS. The clinicians must err on the side of caution, identify its occurrence in the delayed phase, as it is known to be more commonly with than previous cancer treatments. Yeah, this is a valid point. But what about the frequency? Can look up the frequency, we talked about ATO, ATRA. What is the frequency of differentiation syndrome there versus? So I understand there's no good data with solid tumor, but in leukemia world, how common is differentiation syndrome with an acetylene? At least, yeah. And compare that, not just the onset, time to onset. Okay. Uh, Conclusion.
I can probably dig into this reference more because it seems to have that info.
That should be in
Yeah, and that
discussion. This is
discussion.
not the conclusion.
Yeah, so I can
These two are facts.
Yeah.
You know, leukemia, and this is lung cancer, and maybe end with one sentence that um, differentiation syndrome could be considered in a solid patients with solid tumor, um, patients with solid tumor undergoing targeted therapy with IDH1-2 inhibitors, something like that. People don't talk about it.
Yeah.
Okay, I'm
Okay.
good.
And then we just briefly have some figures. I think we went over these before, but it's basically 3 parts. It's the tumor response map that we got permission from Garden about, and then in table form, and then line graph form. But yeah, that's pretty much it for those figures.
Yeah, which one are you using? Both?
We had it as a 3-part figure. So A, B, and C, but they're all kind of repeating the same information. So if anything, maybe this garden map and then the graph are kind of repetitive because it's the same information about the relative amounts of the 3 different biomarkers we're interested in. But at least this middle one has the data on the allele frequencies. But I can check with Dr. Bumi what she thinks is
Yeah, but they
relevant. Yeah.
convey the same information, right?
Yeah. So maybe it makes sense to just keep the first 2 because otherwise we don't, at least in the garden map, it doesn't state the actual frequencies, like the percentages.
Yeah. So I would say, yeah, the first 2, and the third, I think is still meaningful. So make this a supplemental figure 1.
Okay.
Yeah. So C can be supplemental figure 1. Okay.
And yeah, we're still working on the references
Okay.
to update that.
So yeah, nice start. This would be a nice learning platform. So yeah, have Dr. Sumi help you get more clinical data.
Yeah.
We're almost there. Did we decide on what journal?
I'm honestly not too sure about the journal. I know for at least for presentation, we have worked on an abstract for this World Congress Immuno-Oncology, but that's not due until end of March, I believe.
Hmm.
Yeah. but I'm not sure if we talked about a journal for that one.
So try JPOCRR. Okay. Journal of Plastic Oncology Clinical Reports, Clinical Research and Report or something. It's not JQ, it's JPOCRR. So use
Yeah.
that, reformat it into that journal format. Um, so this case has not been reported in an abstract.
We actually had just worked on an abstract. I can share that too.
Ask Bhumi if she's submitted this before or not. Isir, do you know if Bhumi submitted this or not?
For the abstract?
Yeah.
No, not that I know of.
Okay. So yeah, we can submit this to World Long.
World Lung.
World Long.
Can I actually share this abstract really quick?
Yeah,
Is it,
put the link. Yeah, you can
okay, yeah, I can put the link in our.
you can put it in the Google Doc, put the link here, and Sumi, you help Dean get clinical variables. Uh, let's get Eugene O, Ether Kim, and Liam. Three of you help revise, proofread the manuscript. Okay, I want all three of you to help us.
Okay.
Okay, so
Okay, I
Can
can
you
reach out
send the
to.
link for the?
Yeah, I
And-
can send you guys an email afterwards.
the world long sometimes allows table or figures. So yeah, look at the world long format, abstract format, okay? And yeah, work on submitting the abstract as well.
Okay.
Okay, anything else, Steve?
Um. Yeah, that's it. I can talk to Dr. Bumi and make those changes, and then we'll get the proofreading from the others as well.
Yeah, I sent Dr. Elena's email to you through,
Okay. Yeah, I'll follow up with her and Pedro again today and
and then
make sure I CC you.
tell Ben too. Like both of them are busy. Ben should be writing it with you. Okay, so
Yeah.
and
Okay.
keep me on all those emails.
Yeah.
All right, good job.
Okay. Thank you, Dr. Chang.
Let's take a 5-minute break. I have a few return calls. Okay, be back in 5 minutes. All right, I'm back. Okay. Okay, who wants to go first?
I actually gotta go in like 30 minutes, so can I go over my abstract? So I sent the link to the chat.
Um, oh yeah. Oh, request access. Can you give me access?
Oh.
I don't know. It still says
I just changed the setting. Just change setting.
working. Fine. Okay. See it? All right, here. BOLT for IMA. With negative post-operative productivity. Yeah, I like the title. Or absent. Something. Uh, so mutation does not mean without any actionable mutation, it still respond very well to chemo. Yeah. So this
Oh,
is IMA rarely harbors actionable genomic alteration. That's number one. Therefore, there's no good targeted. Number two, this histology unfortunately has been refractory to most standard of care therapies, including chemotherapy and immunotherapy. So that's what I would say. And nevertheless, So being aggressive and not metastases are two different things. So I oppose to what you wrote here. So what I would say, because you could still die with lung filled with mucin, die. That's being very aggressive. It's been met and aggressive. So what I would say is, but if you think about, do you remember a 30-year-old girl who died of IMA? She had lots of this and that. Oh, so it's
Right.
only a certain type of IMA that, so if you remember Min Jung's presentation, our point that she made, and our tumor conference, I think Yunho made a video clip for that. You look at that, we talked about how it spread through airway, not through lymphatic or bloodstream.
Right. Right. I saw the data. Yeah.
I think you have described that like certain types are spreading through um, through airways rather than lymphatic or um, bloodstream. Um, and those certain types of IMA do not show distant metastasis. Um, something like that. So you don't have to link it to aggressiveness, and you can't say IMA as it's only a part of IMA that shows that. Okay, so I think that uh, I would say cancer, like I would say more of like advanced cancer, because that's why if you have a stage one, superficial squamous cell cancer, most surgery, that's usually not a contraindication. So, so invasive cancer or advanced cancer certainly is usually well, we have relative, so relative contraindication for it. This is not true. If you have liver cancer, people do liver transplant, and it's not the standard of care. So that's why writing is all about nuance. How do you, so I would say in liver cancer world, this is a widely adapted practice. Lung cancer world, it is not. So that's how I put it. Uh, solid organ transplant has not been adapted as a therapeutic option for many solid tumors, including lung cancer, something like that. That's a better nuance. Herein, we present the first case. So if you use bolt here, just keep using bolts. Okay, just be consistent. So it is not first case because as you looked at the literature, some other people have reported case series and that has been published in NJM. However, there is a breakthrough in technology. So if you, I don't know, you may remember it, Dr. Barat said what he did was, so this is why it has to be written with Dr. Enkit, what he did is most bilateral lung transplant happens like you take out this lung, let this lung breathe for you, and then put the new lung in, and then take out the other. What Dr. Enkit did not want is contamination. Like you take out this lung and you put the new lung in, but then there's a time when both lungs are there, then by airway, you can have cancer cells because air is constantly moving in and out, right? So the cancer cell from this old lung can go to the new lung. So, but how do you prevent that from happening? You take out both lungs at the same time, put the new lung at the same time. And this is the first time that this type of transplant has been done. So this is simultaneous double lung transplant. And he published this in JAMA, okay? And look at Ankit Bharat, JAMA, I think it's JAMA, not JAMA Oncology, I think it was JAMA Network. You can easily find it. I think it's worth showing you guys. So I think we should describe that. We can kind of write a little bit, and then I'm sure Ankit will write more about it. So let me share. Do you guys see this?
Yes.
So read this, and a lot of methods, like the surgical methods, are here. So this, like Northwestern patient who got COVID-19, ARDS, they transplanted 102 patients. These are the criteria. Maybe read this number 7 reference too. So here, double lung transplant using central, this is the ACMA. Here's the supplement. So this is why they use ECMO. But so if you can write that this is cardiopulmonary bypass. So this is an amazing victory of modern medicine, like with ECMO, like you can the people can live in the operation room without lungs. You have a machine that will do the gas exchange for you. Okay. So this is a COVID-19 patient. So their lungs are destroyed. So um, they need ECMO to sustain life. Okay. Now, because their lung can't function anymore, there's no gas to exchange. All the lung tissues are destroyed. So they live on ECMO. Okay. And they got new lungs. Now this is the COVID case, but in lung cancer case, what we're trying to achieve is to reduce the risk of aerogenous, okay, through airway contamination of cancer cells from one lung to the other side. Okay, so this is the concept that we want to educate to the readership. So write about the ECMO in general, but write about the technique that we've used for the first time, which is using the ECMO and simultaneously taking out the cancerous lung and putting the new lung together at the same time, not in a sequential manner, but in a simultaneous manner. And if you do sequential manner, you might not need ECMO. But if you do simultaneous, you have to use ECMO. Because there's a time period where your blood will have to circulate through the ECMO to give us adequate oxygen to patient body. So, so describe ECMO, describe the technique, and then say we're doing it in order to reduce the risk of cross-contamination of cancer cells through aerogenous contamination. So I think we can claim and maybe look at the NEJM paper, the previous case reports of lung cancer transplants. I don't think any of those used ECMO, and it was those. I mean, that's my understanding, but and Dr. Enkit can tell us more about it. But I think we can, at least at this point, say simultaneous double lung transplant. Maybe we can make that word terminology. Maybe we could say this is the first simultaneous double lung transplant. And I think they like the word double. This is lung. Do they say which one's double or which one's not double? Oh, here, 62% did ECMO. I don't know. What did they say about bilateral versus one? Anyway, and look, and then yeah, look at previous cases and say probably this is the first one utilizing ECMO and doing the simultaneous double lung transplant. But my point is, and I will I can put this in the chat room so you guys can write it later. Go back to the Google Doc. Okay. Results. Stage 3, chest bronchial biopsy. I would say, where was the biopsy done? The biopsy of the left upper nodule or something. You know, I would put where the biopsy was done.
So actually, he had three times of biopsy. First was left, and then the second was right, and then there was third biopsy that was done by both at the same time. So should I just add like
So I would
both?
put that initial biopsy was, I don't know if there's probably a word limit, but you know, I would list before he had surgery, if he had one, you know, 2 or 3 biopsy of where was done, showed well differentiated nuisance data of carcinoma, invasive, put invasive. There's non-invasive. Or you can put IMA here. Just be consistent. I would say all followed by disease progression. That's because of toxicity, but because of disease progression.
I see.
Yeah, you don't have to write that, but all followed by. So I would put this here.
Oh, so okay. So I just
It doesn't matter what the patient presented to me. The point before
point is the surgery. Gotcha.
so this is how you present in the morning report. Like, well, when I first saw the patient, the patient underwent this. When you write a, you know, formal case report, you have to on the patient. So when this um, as a, you know, fail, you could say patient progressed on all 3 standard of care treatments, including this, and that. Patient also underwent clinical trial. But the first, you know, CT scan, you know, after first cycle showed progression. So, you know, I guess, and then, um, although hospice was discussed, patient completed with kind of workup. He passed all the workup, you know, and then all that. Yeah, I think that's better. So I think the thought process. So here, I think this is better served after patient is diagnosed and then did not have any actionable alternative mutations, right? So talk about the biomarkers and then talk about standard of care and talk about clinical trial and then talk about that he was a recommended hospice, but he uh, um, came to us um, since our center was known for bilateral faults. Um, we because our center is known to be for our center had a reputation seeking. Well, yeah, I think that portion is important that we didn't recommend it to them, like patient, you know, um, patient um, wanted to be screened or patient wished to be screened for double lung transplant. Um, as a last resort or something like that. And then talk about how his tumor did not have this in the past. Um, and then he underwent this workup and all like the mediastinoscope of all the lymph nodes did not reveal any cancer cell involvement. But that's really important. During that transplant workup, we did mediastinoscope and EBIS again. Everything showed that there was no mediastinal or hilar lymph node metastasis. Um, Therefore, patient was determined to be a candidate for bilateral lung transplant. So talk about the workup and then talk about um, um, the course. Then talk about you know patient showed response to lenvatinib, which um, made it possible for him to stay alive during the workup, right? But then he finally got admitted. Vault. So is it is he now 4 months out or something like that? Just you know, can't remember. Was it? Yeah. Um, Question is how many months out from surgery or something like and every time or not ctDNA, you write it out or you somewhere or circulating tumor DNA. I always write out circulating tumor is performed after 1 month. because not many people know about Signatera, I would say, I think it's 16. 16 genes were selected from the lung tissue from the transplant transplant surgery.
Yeah, molecular residual disease. Oh, okay, yeah. Yeah, I didn't write that out.
Yeah, no, you write MRD here. You can write MRD. What I'm saying is, what is the of how do you assess? Um, you can say MRD was assessed based on the 16 unique gene mutations found from his tumor resected during transplant surgery. Okay, so the 16 gene, it's not NGS, 16 gene, the CTR was done. So go to the Signatera homepage and rephrase how they describe their platform. You can understand. So you said NGS was done and there was no actionable mutation, but maybe because we know non-actionable mutations, describe what you found. You know, mutations, no actionable mutations were found, but you could still describe what were the mutations that were seen. Okay. Near normal. Okay. Yeah. I don't know if this is uh, the better expression, race, regained near normal life. Back to normal routine, but I don't know, in medical, you know, operation. In subsets of motion, such as IMA, I would say without distant metastasis. And with no uh, lymph node involvement. I think that's also important. You have high lymph node, that's going to be a source of metastasis even after surgery. It's important to have negative egos. Some people look at that as a local disease, not systemic disease. So it's important to emphasize both that no lymph node involvement as well as no distance. I don't. So pathological, I think you can only have it like when there's radiological evidence. You take it out and put it on the microscope. Right? So I don't think you make sense to put both here. Um, does not. I would just say post-surgical ctDNA-based MRD assays can be utilized as a surveillance tool to complement radiological surveillance. Better, yeah, better. I would say warranted. After the second sentence, I'll put we are planning to start a registration trial, registration trial or registration prospective study to enroll patients with here I would say patients with bronchial alveolar carcinoma of lung. Doesn't have to be mucinous. That's what we talked about with O. It could be both mucinous and non-mucinous. So I don't want to emphasize mucinous too much, but we don't use the term bronchial alveolar anymore. So maybe we are planning on opening a trial that enrolls patients with lung cancer, refractory to all standard of care and experimental therapeutic options who do not have any evidence of lymph node disease nor distant metastasis. Most of whom demonstrate bronchial alveolar spread or aerogenous spread of cancer in bilateral lungs or something like that. You know. Yeah. So I think we should talk about the trial we're opening and so that's why I think if the World Lung allows, I think we can write a separate abstract title of the trial, and we talk about the eligibility and how many patients we're planning to enroll, what's the eligibility, and what is our primary endpoint, and all that. And O has all that information.
Okay.
So work with O to write that clinical trial advertised abstract. People publish that as an abstract. It's a way to publicize the trial and increase enrollment. But the caveat is some only allows the ones that actually has the IRB number. So it might look into that. But you could put one sentence that we are planning to open this trial. Oh yeah, and then you can emphasize again one more time that this is the first simultaneous bilateral lung transplant utilizing ECMO um, done for lung cancer treatment. Something like that. I think you should put that in the first sentence, the first thing. Yeah. Any questions, is there? I think you're frozen. Okay. So edit it in the world long format. I think we have 3 weeks left. Okay. Um, Grace, you have to go too. So do you want to update?
Oh, me?
Yeah.
Oh, yeah. Dr. Leo and I were able to submit both our abstracts to ASCO regarding the thematic analysis. Yeah, we had a couple of questions, I think. I don't know if Dr. Liam already asked you. Okay. But we were wondering, like, how you said we should add like everyone from your team to the authors list. We were wondering if Leslie also goes in there or if it's
Leslie? No.
okay. And what else? Yeah, so we submitted that. I've been a little behind on the variant classification project, but I did get to talk to Dr. Pedro, and we like thought of like what we should do for the next meeting. I have to send out an email to everyone to see what time everyone would be free to meet. Because last time it was just me and Dr. Pedro, so we think it'll be better if we have like Dr. Isa and also like Eileen and Lena on the call as well. But yeah, now that I'm done with the ASCO abstracts and I'll be done with an exam today, I'll be able to focus more on the variant classification project coming because the deadline is approaching. Yeah.
That's good. Yeah. So yeah, it would be good if Isa or Eileen can join, but you're the leader. The schedule meant for you at least weekly basis, and yeah, let's find time for Luna too. Okay. All right. Anything else?
No, that should be it.
All right. Good. Liam, any updates from you?
Yes, just a couple of things, just to add to what Grace was sharing. So we did submit everything. Trevor gave us some, valuable feedback. So we incorporated his feedback into our abstracts, both of them.
How was it?
Yes, so he gave us a pretty long, kind of comprehensive list of comments that were really helpful. So very grateful for that. And in light of that, we made some changes. One of which was I share this just because we thought you should know. We took out the Robert Lurie Northwestern Memorial Hospital name out from the abstract because Trevor's comment was that it's probably better to write it neutral, as in like a metropolitan healthcare hospital setting. So that's not the exact phrasing, but that's kind of what he was going for, and we were in agreement. So that's what we just changed it to. And then there were just some small questions that Grace and I were able to sort out. So in terms of the abstract, I think we're all set. We'll hear back in April. And the other remarks I have will be regarding pacemakers. Eileen shared it in the chat, but she is still working with Dr. Liesel and creating that advertising video. So hopefully they'll have that soon. I have Eileen and Sally and the undergrad students looking into ways to potentially spread the word and the ad so that we can recruit people. So they're looking into various ways and methods and routes in which or through which they can advertise. And we also remember that you wanted to reach out to the high schools in the area. And so Sally says she's going to reach out to Lena. We think she'll be the best contact we have to reach out to high schools. So she'll reach out to her. And we also have Dr. Sumi's gathering the patient information for the 3 patient interviews. And we have assigned Eileen, Emma, and Sally to do 1 each.
Yeah.
And then, so I told them to, I'll be relaying that information once I get that from Dr. Singmi. And then we are hoping to get those interviews done by within a month. So I gave them about a couple of weeks to reach out to the patients and actually do their interviews, and then a couple of weeks more to edit the videos and make it publish worthy on YouTube. And also Sally and I, we were able to test the new equipment, the videography equipment we purchased. Everything seems to be working well, and it definitely improves the video quality a lot. So we'll be glad to show you some of the example footages we took either tomorrow, probably tomorrow.
Yeah.
Yeah, and then so I think that's pretty much it for now. With one more thing, Sally is looking. She's working on the application process to make up pacemakers a registered NGO. So that's going to take some time. It's just a lot of paperwork, but Sally is on it, and she'll keep us posted on that.
Yeah.
Okay, and then the other reports that I have is with the case reports that Dr. Yunho is working on, as well as the one with Dr. China and Horyun and Suno. And I know Dr. Yunho has to leave soon, so maybe we can start with the one he has to report first.
Okay.
Thank you. Dr. Chip, could you check the ASCO abstract? I sent Google Doc.
Oh, where is it? I don't see it.
In the chat room.
You sent it as a direct message.
Ah, sorry.
Oh, Liam, one thing we also decided is so Eugene O will work with Sally to interview
Vivian.
volunteers.
So that's a 4th patient, right?
It's a 3rd patient.
That's the 3rd patient. I'm just pulling up.
And let's just assign 1 each. And Sumi, do you have a preference? Sean,
Not really.
and then the other one was Albert Curie.
I don't mind.
You don't mind?
So Vivian Penu is going to be Sally and Dr. Eugene.
Mhm.
Okay.
Let's Liam, I think you should do one with one undergrad. So do Albert Curie, okay?
Okay.
And then Sumi, you could do
Paul.
Paul Sean. Yeah, he's awesome. Paul Sean. Yeah, and then there's assigned undergrad for each one. And there's a 4th patient. His name is Sunghyun Park. And he's going to be interviewed in Korean because his native tongue is Korean. And Ether will interview her. And I think Eugene O is going to
Help her and record and
And Shana will do the video editing. Shana. So that's the fourth project for patients. Okay. So let's make sure we do it within 4-week time frame for all these four different teams. Okay. Good.
Sounds good. Was there a particular reason you wanted to put Sally on Vivian? Last time we discussed Sally should interview Paul. I mean, not that it's an important detail. There's no big problem changing the teams.
Who was doing Vivian then?
So initially Emma was on Vivian and Sally was on Paul.
Oh, I see. No, there is no. I mean, doesn't have to be Sally, but
Yeah, I mean, it really doesn't matter. It can go either way.
I guess you can know Sally contact, so maybe just let you can work with Sally.
For convenience, yeah.
Okay.
Because I have already known Excelis for a while, so
Yeah, we taught Sally in class, so let's pair them up.
Sure, no problem.
you
Okay, so that's for the pacemakers. Okay, all right, you can proceed.
Yes, I sent the Google Doc. Thank you.
No. Okay, tell me what you fixed or
Yes, I changed the serum proteomic signature as a potential predictor. I tried to focus on very straight result in this abstract, so I wrote in the first in the first paragraph in the title, yes, and I I added that very straight in the background, very straight explanation. Very straight is a serum proteomic signature that assigns a binary classification of very straight good or poor that associated with treatment outcomes of cancer patients. So I tried to uh, show uh, very straight in the background also.
okay.
In the method, you recommend that I have to show how I gather the data, and so I added the sentence that clinical pathology data were retrospectively gathered and analyzed it. And I added also various testing was carried out by biodesics, Boulder, Colorado. Yes. I try to focus on very straight in this.
How did you do that?
Pardon me?
Why did you put the very strap?
Uh, hmm. In my opinion, serum proteomic signature was a little vague for me. So, is it a good idea?
I mean, it feels like you are.
Hmm.
This is the only thing you wanna emphasize. I mean, you found some some more meaningful things.
Yes. Yeah. Uh, Performance status and PDL1 and TTF1. Um,
Presence of bone nets, right? And
yeah, bone mass. Yeah, yeah,
PDL1.
yes, and NLR thrombocytosis.
No, I just worry. I like. I think we can emphasize, certain programs, but I think how about this? Do you want to make this into two abstract?
A two abstract?
Yeah.
Yes, it is possible. How can I?
It's a little bit tricky because you're working with. Well, it's not that tricky because see, you have 203 patients, right?
Yeah.
But how many actually do have very strat data?
Only 40.
Only 40, right?
Yes.
Yeah. So I think you can do it. You have
Ah, okay.
203, and you can talk about everything except very strat in one abstract.
Mm,
Okay.
okay.
Did you do multivariate analysis in the abstract or not yet?
Not yet. Actually, I saw tomorrow I asked for help to Dr. O and hopefully she'll help me. Actually, anybody know about it. Yeah, I asked to almost everybody in Dr. ChaeLab. So actually, uh, yeah, I know that I have to gather that below 0.05 p-value data. I know, but it is categorical data. So how can I put the categorical data and how can I determine that it is hyperprogression or not? Because in my opinion, it is a function. So I don't know how to make a table and I don't know how to put the number in there. So
Okay, I think Eugene O can help.
yeah,
Yeah, maybe I
yeah,
can help you. Like, when is the due date for all of that analysis?
For the manuscript.
yeah,
Oh,
yeah, yeah.
For abstract, we're good with just the
okay.
you know.
Then let's talk about that later.
But didn't you talk to Minjung about it? Wasn't she
Yeah,
one?
I talked to with Minjung and Dr. Minjung helped me to figure out what is the multivariate analysis in medical article. So I get to know that I gather the data below 0.05 and she explained about the stepwise removing technique, but she didn't she doesn't know about how to make a table and how to analyze through the statistical ways. So
Okay, you didn't know. You're next.
Yeah, I'll do my best to help you guys. I think we have to do multi-regression analysis or something else. So
yes, yeah, multiple regression. Yes,
multiple regression. Yeah.
yeah, multiple logistic regression.
Yeah.
Yes,
So do that. Yeah, yeah.
Okay.
thank you.
Maybe. Um, One way to do this is, I know we don't have time. Today is the deadline. So what you can do is you can put the previous title, which is not the proteomics,
Ah, okay. Yeah.
report everything the same way and just take out very strat from this
Okay.
and submit to ASCO, okay? That's
Okay.
easy. You can do that for today. Now, write with 40 patients and have
Yes.
the title.
Yes.
And uh, you can rephrase a lot of it and pick out just highlight the berry strat
Okay.
and write a, and I think, and then prepare that for word long.
Okay. Yes.
Oh, yeah. And 40 patients, and within just 40 patients, you can just using the 40 patient, you can still look at these factors. And it's going to be a different odds ratio and different p-value. You understand?
I understand, but I think that if I select only 40 patients, that thrombocytosis and LDH, HLA1, there is only, I'm not sure, but only 5 or 6 numbers. So,
So don't do those.
per-
Don't do those.
yeah.
So what? Only the 40 patients, the data that the 40 patients altogether will have.
Demographic data.
Yeah, just look at those. I mean, they should have platelet numbers. 40 patients platelet numbers. You should have it.
Platelet number.
Yeah, it's just 40 patients. And if you don't know, ask Liam. Okay.
Okay. Yeah.
Just 40 patients. And so just generate data based on the 40 patients and emphasize very strat in that 40 patients. That will be a separate abstract for a world long. Because it's like, I think all the other factors are really important, and I don't want to de-emphasize it by just, titling the very strat in the title. So work on that. I think for ASCO, you're good because you're just picking up the very strat, and then for world long, you still have to.
Okay.
In the meantime, manuscript is the most important thing. So
Okay.
work on it. Yeah. Any questions?
I want to ask about the authors. I wrote by myself, but could you check the authors?
What did Dr. Chiu do?
Actually, Dr. Chiu and Dr. Hanson didn't do anything in this abstract, but they gathered the data in a raw data. So in previous AACR abstract, you said that I add the Dr. Chiu and Dr. Hanson in the authors.
The raw data. They generate the raw data.
Yes.
Yeah, I'm okay with this.
The sequence is okay.
Yeah, if Eugene O helps you, you can add Eugene O here too.
Okay. Also, I have one more question. I want to ask about the category. Yes.
What is the category?
Category and topic. And can I share my screen? Okay. In the category, I selected the developmental therapy, immunotherapy. In this area, I couldn't select the hyper progression. So,
Oh, it's not developmental therapeutics.
yeah, then
Do what's this category? Is this a therapeutics or
category. Then lung cancer.
oh yeah, biologic correlates lung cancer.
Okay, I got it.
Wait, this is local. So metastatic. Because our patient's metastatic.
Oh, metastatic. This
Biological.
correlate. Okay.
Lung cancer. Interesting. What are two dots for?
So one is the primary category, and then the second dot is a secondary category you can select. So yeah, you can choose two like that. The box on the left is the primary, the one on the right is the secondary.
Okay. Yeah, I think that's better. Good, good. Good that you asked. So you know you'll be the presenter, but are you able to come?
Oh, I'm not sure if I got a message, I can go Chicago because it is but I'm not sure. Yeah, but if I cannot present, I will ask for it to
You can ask.
Dr. Lisa. Yes.
If you don't think you can go, you can email ASCO and change the presenter to Ethan.
Okay, okay. Yeah.
Good. Anything else?
That's it.
All right. Very good. Thank you.
And then we have the case report that Dr. China Horyun and was working on. Should we go over that now?
Yeah.
Okay. And while I share the link, just one quick question regarding the abstract submission that we had. So when we were listing the authors, all the clinic members, for the section of COI disclosure, we noticed that they were asking if they were hired by a healthcare company, and we just declared no to everything for now. But then we were a little confused because technically all the workers at the clinic are hired by Northwestern Memorial, so we weren't sure if that was something we needed to consider as something to be disclosed or no.
Oh, I think healthcare company is a company like more like for profit company.
Okay, so hospitals don't
Yeah. No,
fall under that category.
we're fine.
Okay. All
So,
right.
Yeah. So you know what updates were made?
Oh, so for this one, I can present. I worked with Dr. Jina and Horyun pretty extensively over the weekend
Okay.
to create this final draft. So we've made all the adjustments, necessary adjustments, and then the biggest kind of change came in the discussion section. We took out a big chunk of it just to linearize and clarify and streamline the whole message of this case report. So the biggest difference that we made, one second, is the order of the 3 points that were discussed in the discussion section. So initially we were talking about how, the first point was the fact that it was monotherapy. Number 2 was its CNS involvement. Number 3 was the fact that this patient had rare mutations. We brought up the last point to number 1. So now the order reads, this patient having these 2 very rare mutations, that is uncommon. Number 2, he was put on amivantamab monotherapy. Number 3 is he showed clinical improvement with radiologic improvement. Showing that the CNS lesions had response to this. And some of the highlighted portions are areas we just highlighted to note that we could take that out because we recognize this is a case report and it's a pretty lengthy one at that. So we know that most, it depends on where we're submitting to, but we know that it's probably going to go over the word count. So like the highlighted parts are areas we can just kind of cut out if we needed to. So I think we are pretty confident in submitting this to wherever we can now. So we just wanted to confirm everything with you and then also ask for your advice on where we should submit.
Oh, we didn't decide on the journal yet?
Mm-mm.
JCOPO.
JCOPO. Okay.
Journal of Clinical Oncology, Precision Oncology. If you don't take it, then JTO. Yeah, JTO. If JTO doesn't take it, then JTO CRR. Okay. So those are the three journals in that sequence. You don't have to send the editor email, just submit it. I know they usually take these notes.
Okay. So does this look good for submission?
No, this looks good. So here the osimertinib was discontinued the side effects. So the side effects, describe what it was.
So here, the side effects that we are referring to is the pneumonitis.
We talk about it.
Yeah, so in that paragraph, like the first two lines or the second line in the end.
Yeah, so I think so pneumonitis, which was attributed to osimertinib. You have to be clear.
Okay.
I would say pulmonary toxicity to make it pulmonary toxicity. It's still be. Okay. Yeah, so I think all the blue things that were added, it's pretty good, adequate. Table. So if you need more, oh yeah, this is appendix. So if it is appendix, you just put supplemental table. Okay. Just if this is a figure. So figure is a figure one. Yeah.
I will count the figure number. Yeah, I didn't set the figure number.
Like did you? Is it supposed to be figure 1, 2, 3?
I'm not sure how Dr. Gina make a order, make a sequence of the figures, but is it okay that that two that is almost the same? Yes, 25.8.2 non-detectable. So Dr. Gina concerned about, oh, it is almost same results. So is it important or is reportable? So, but I made it, but so I want to be confirmed by you.
Uh-huh. What is the figure number for this? Do you have this is the oh, so this is so you
Yeah, that figure is how the CT scan image was changed from 6 weeks.
figure the figure title and the figure legend. Figure legend should explain everything about the figure. Even without the manuscript, people should be able to understand what the figure means. So I wouldn't put this in the box. I would put the figure title. Figure one. So you need a title for the CT scan.
Okay.
Imaging, pre and post treatment imaging.
Okay.
That could be the title, and then you can, and then as a and below the title, it's too long to be a title, right? So you can bold letter the title, and then you can describe the design in the picture. Design so, and then the is down. Same thing. This is figure one. This is figure two. Figure three. And title and describe. Here, baseline and post treatment, we need to know what's the time frame. Is it 2 months or what is it?
Dr. Che, I cannot listen clearly.
No, I said for this one and this one, you need figure table and legend, figure note.
Okay, yes, I will make it.
Yeah, the question, like, I don't know if you actually need it. I actually want you to take out the 0.00, just 5%. And maybe in baseline, the post treatment, you can put 3 months, the 2 months, whatever.
Okay. 3 months, after 3 months.
Say if you need more space or something, I think this graph could go into a supplemental figure. But if you don't have any restrictions in figure or word count, I think you can still leave it figure 1, 2. So I would put this figure 1 and then in this figure, these are the same thing. So I would say this is figure 1A, like capital A, figure 1A. And I would put this as figure 1B. So it's the same thing.
Yes.
And I would put this below this and add it as a one panel. Maybe not as one, because this is No, they're two different. Just take it back. Figure one, just make this one figure two, make this figure three. Figure three or figure something like that. And yeah, first formatted into the JCO field. Yeah, you're pretty much done. No, I think we're all almost.
Okay, so once Dr. Yuno is able to finish editing the figures and tables, we're good to go ahead to submission, right?
Yes.
Okay, thank you.
Thank you.
Um, let's go to stats, but let's do bathroom break. 5 minutes. Okay, I'm back.
Okay.
All right, Stas. Show us what you got.
Okay, so I'm just going to talk about some of what I found and kind of what my ideas are. So Tempest sent me about 180 or 160 accession numbers. Of those, I only had access to about 93
Why?
patients. I emailed him and he gave me a very vague answer, saying that sometimes the accession numbers change, sometimes they aren't accessible, that he'll look into it, but he's not very responsive. So I'm gonna bug him again to get the rest.
Yeah.
Of those 93 that I had, only 12 had both Gardant, and we had screened their clinical variables, or not the variables, but kind of the clinical outcomes
Okay.
in treatments. Because we had been doing our screening using Gardant as our kind of patient list.
Mhm.
Of those 12, 3 are on some form of TKI, that's EGFR or ALK. The ones that are left, that leaves 9. And these 9 are taking some form of immunotherapy. So either on its own or in combination. I looked to see if there were relationships between the cfDNA variants. There weren't any. And of that group, 4 had PyClone, Gardant PyClone. And I know the sample size is really small, but this was probably the closest to being statistically significant at 0.08 for the p-value, where higher PyClone correlates with longer treatment time, which is interesting. But the sample size is small. Now, if I look at the Gardant data set without Tempest, there's 38 patients who are naive, who have treatment time. So I instead of focusing on PFS, I just focused on the first therapy treatment time, just because that was a lot easier to control for. And of those 38, 8 were taking some form of EGFR inhibitor. And this is where I found, I think, the most interesting relationship, but still not, I don't know if it's abstract worthy, but this goes back to the paper we read about instead of using axon-based mutation locations to choose TKIs, you use structural-based locations or structural-based logic. And I found that out of those 8 patients, 6 had mutations that were concordant, as I called it, with the therapy. So they matched what was predicted by that paper, that if an individual has that mutation, they will respond well on that specific therapy. And that group had an average treatment time of 20 months, while the other 2, so 6 were concordant, the other 2 were not, and they had a treatment time of an average treatment time of 3 months. So that was the only real interesting relationship I found in this group. It's not new because there's been a paper published on it. What is new is that this is entirely being done with liquid biopsy and not tissue, or this relationship is being seen.
Tell me what has been reported in tissue, the data.
So that paper, let me pull it up. Let's see. So they started with 11,000 patients. From, let's see, from MD Anderson. And so they used those 11,000 to build yeah, so they used these 11,000 patients to build this but to study this relationship.
You want to share your screen, whatever you're looking at?
Yeah, I was just looking at the paper. Where is it? Right. So they started with 11,000 patients, and they brought that down to 1,000 that had EGFR mutations. And they were curated based on what are considered classical and atypical mutations. And let's see. Yeah, so they had 11,000 patients, and they kind of studied this relationship, and then they did all of their experiments in vitro to generate this plot, where blue means that they're going to respond and red means that they won't respond, because it correlates to the tumor growing or not. And so of those 8 patients, 6 had mutations that matched that received therapies that they should respond to based on this structural relationship. For those of you who haven't seen this figure before, on the right is the 3 different, or I guess 4 different classes of medication. And then on top here are the different structural regions. And then on the bottom are all of the mutations that they studied. And so this was the only like real interesting relationship that I found that one could argue is statistically significant. I didn't look at p-values, but if you have 2 patients that have a PFS or a treatment time of 3 months versus 6 who have an average of 20 months, just on kind of a qualitative glance, that seems different, but the sample size is small.
But the colors were generated using computational analysis, right?
This?
Mhm.
Right, but they used an in vitro assay to generate the response. These BA-F3 cells. And so if the cells proliferated, there was a higher log mutant to wild type ratio. If the mutant cells didn't proliferate, then they had a lower log mutant wild type ratio.
So they made all these cell lines, like the x-axis?
Yeah, so they made all these cell lines, and then they exposed them to these different drug classes to see if they would respond.
Okay.
So, if you're a patient that has this succession of mutations, so it seems like the more mutations you have in EGFR, the worse it is, which makes sense because there's always a mutant that's going to be able to be treatment resistant. And so that's why on the left side, you see basically this giant block of red. While on the right side, you have classical mutations, which are kind of the mutations that are used to design these drugs, which is expected why individuals would respond better, or individuals with these mutations would respond better, kind of intentional. And then you have everybody in the middle. And that's where I think a lot of the decision making needs to happen. But the point is that at least those 2 patients that had shorter response times or shorter treatment times were not on drugs that matched this logic or were consistent with this logic. Or rather, to put it a different way, there were drugs that they were more likely to respond to that they did not receive.
Hmm.
But the 6 that did all had treatment times of 20 months
Hmm.
on average.
Can you, so our data, how many mutations did you look at? EGFR, how many patients?
8 patients.
Okay.
So these were, and the reason it was 8 because these were all treatment naive. According to all treatment naive, and they had Gardens.
Hmm. Just garden only or both?
Garden only.
Okay. And do you know what mutations they had?
Yeah. So the ones that didn't respond had a mutation L861Q.
Okay.
That one is
Are they all atypical 20?
no. So L8612
Huh?
Q, this one is considered a classical mutation. And this patient was receiving erlotinib, which if you scroll up, it's
Oh,
red.
I would say classical like. Yeah, yeah.
Classical like. So this was a classical like mutation. They were receiving erlotinib, which if you look at this column, I know it's kind of hard to see,
Yeah.
significantly redder than everything except for these two. So of the options, it's not the best. A better option would have been afatinib, for example, or the best option would have been decamitinib,
Okay.
for example.
So how many months was this patient on erlotinib?
4 months.
Got it.
And then the second patient that wasn't, that also didn't respond, he had the exact, and I don't know, this might be the same patient that was mentioned in the case report that was talked about earlier. This patient had both of the 2 rare mutations that were mentioned in that report.
Where is it?
8289, A289V. That was the rare one. No. I believe that was the rare one. Let's see it here. And then the other mutation was G719A, which is right here.
Okay.
And this patient received osimertinib, which if you scroll up is pretty red.
Oh, it is red. Very interesting.
Yeah. So
Dr. Seung-mi, I think you should cite this paper and describe this in vitro finding from the cell line that has the BAF3 cells with this mutation, which kind of predicted that osimertinib is, will be the cells will be refractory to osimertinib. So I think this is a really interesting finding to discuss. So Stas, why don't you I don't know, copy the address up here and put it in the chat box so Dr. Seung-mi can
absolutely
use this for the manuscript.
But yeah, so
yeah, tell me all about the. I need to hear about all those 20. What they are and whether it makes sense.
The 20.
Yeah.
The other ones, not the EGFR, not the ones with EGFR mutations.
No. So when you say 20 patients, are they all EGFR or?
No. There's only 8 with EGFR. So there's
8.
only 8 EGFRs who have clinical data that we went in and screened them. And they're treatment naive.
They're treatment naive.
So they came in, they were diagnosed, they were worked up, they got Gardent, and then they received their EGFR therapy based on the Gardent.
Are out of, you said 8?
8.
Are they all atypical or when I say atypical, are any of those exon 19 deletion?
There are a couple. So there's one who received a fatinib and they had an E746 to A750 deletion, which I believe is exon 19. And they received the fatinib and they did really well, 33 months.
Hmm.
So like that's this category, I believe, exon 19 deletions, which is kind of just a broad category.
Right. Um, okay. What about L858R?
Oh, right. There was one patient, he had, let's see, maybe there was more than one. There's at least one. There's two. Yeah, there are two patients who had L858R. One of them received erlotinib and chemo, and he had, he had a 20-month L858.
But just chemo? Wasn't there any EGFR drug?
There was erlotinib plus chemo.
Plus both?
Yeah, for him.
Okay.
And the erlotinib, it's blue. So that makes sense. And then the other one, he received osimertinib. He had two mutations. He had L858R and I966, oh no, L966I, which isn't here, but
Isn't here? Okay.
that one's kind of rare as far as I could tell. Anyway, so he received osimertinib and osimertinib has a similar response as erlotinib.
Like more than a year or something like that?
22 months.
Okay. So other than those three, 5 or 8 are less common mutations.
Yeah. There's also K754E. But this patient had that mutation and the deletion.
What mutation?
K754E.
Can you find it here?
This one right here.
Okay.
And they received osimertinib and then afatinib. I think they had toxicity. But both of those are considered responders.
So is the patient still on it? Or like
no, I think they passed away.
was on osimertinib for how long?
That I'm not sure. I know together it was 19 months.
Okay. Still not bad.
And then after that, this was interesting. They were put on erlotinib because I think that they had a mutation and they were on that for 12 months. But I need to confirm that.
Okay.
I need to confirm that they were switched because of a mutation. But yeah, so at the very least, in this case, the first line therapy kind of matched this prediction.
Right.
Or the first therapy. So yeah, I don't know if this is reportable. It's definitely an interesting finding. I think if the sample size was larger, it would be something I could write about, but I don't know, 8 patients seems very small.
I know, but you found those mutations by looking at Guardant table, right? Guardant
Correct.
patient table, and just looked at EGFR ones, right?
Correct. Yep.
What about Tempest? Were you able to screen?
So with Tempest, the issue is they don't do, they just give a start and basically a location for the SNP or for the deletion or for the indel. They don't give specific gene mutations. I obviously run that through a program that would do that. I just haven't done that. Their data isn't as convenient to work with as Guardant, but yeah. I think that as far as Guardant goes, what would make a lot of sense is to screen the patients that we have Guardant for, screen the patients we have Tempest data for regardless of whether they have Guardant. Because originally we started with Guardant and we started screening only patients who had Gardant. And now that we have Tempus, there's a very small overlap. So the nice thing about Tempus is that we always get a TMB and we always get a PyClone value. I looked into patients who had both Gardant and TMB. Sorry, had both PyClone, Tempus PyClone and Tempus TMB. Based on what Liesel sent me.
Yeah.
Based on what the undergrad screened, I think last year. And there weren't any significant relationships, but there were only like 5 samples. There were only 5 individuals who had both, who were treatment naive and had both of those. Gardant had both TMB, Tempus TMB and Tempus PyClone. The point, I guess what I'm trying to say is there may be interesting relationships. We just need more of a sample size to really find anything. And to get more, I'll have to just screen patients who have Tempus, regardless of whether they have Gardant, and see how many of those are treatment naive. And then.
So Tempus treatment naive is very, because
It's more likely.
it's more likely to be because they usually use the first diagnosis by Gardant is trickier, but
Yeah. But that's what I can do next. I mean, I can't do that today, unfortunately, but I just don't have enough time to screen,
of course.
93 patients. But over the next couple of weeks, I can do that and we'll have more data if we want to replicate the relationship we saw with TCGA. I think that would be the easiest way to do it.
Yeah.
Let's see, what else did I look into? Just looking at Gardant, I looked at 10 patients with at least two dates. And there were 10 of these patients, and I split the groups into 5 who had kind of in the top half and 5 in the bottom half. And of those 2 groups, the ones that had longer treatment times had a decrease in their cfDNA percentage. So that's expected. If someone's responding to a therapy, they're going to have less circulating tumor DNA. And that's kind of what I saw. And those that didn't respond as well actually had increasing amounts of cfDNA. Or ctDNA in their cfDNA.
Yeah. And that's all Gardant?
Yes.
Okay. And how many patients?
That was 10.
10 patients.
Yeah.
How many were responders in the 10?
How do you define responder? Because some of them, I mean, there were some that were only on the therapy for 1 month, and then there were some that were on the therapy for 20 months. So those that were in the top half of that range had a decrease in their percent cfDNA. While those in the bottom half had an increase. But there were some that decreased and still progressed. So
Decrease and still progress, meaning?
Or sorry, we're taken off the therapy earlier, or weren't on the therapy as long.
Okay.
And then there were some who had a longer treatment time, but had an increase in cfDNA. So it's not kind of a hard rule, but since there's only 2 data points, you don't know when that cfDNA spiked. There could have been a drop when the patient started therapy, and then right as they were, when they started to progress, when that was detected clinically or radiographically, that's when everything spiked. So it's Yeah, I'm sorry, I don't have any interesting findings for you, but
No,
the sample sizes are just too small to really make any significant conclusions. And the sample size shrink with every step because either data is missing or you want to normalize.
mhm.
You want to compare only people receiving similar treatments to each other. But the nice thing is this data set does have quite a few individuals receiving IO and combination therapies, which is nice. Yeah.
Yeah. And these are all lung cancer patients. So
Correct. They're all non-small cell, like some are squamous, some are adeno. The vast majority are adeno, but I know we shouldn't lump them together based on everything we've seen, but a lot of groups do. And if we have small sample sizes, I think it's something that we can get away with. But
yeah. Well, I actually believe, some of the things you described are worthy to be written for abstract, but I think we have to sort of save our energy and just really focus on the things that are going to matter the most in the end.
right.
I mean, the dynamics, the change, and all that. But I think the reason we started this project is the heterogeneity, like, like the variance, TMB, and all the clinical factors. How do they all interact? So that the question of Tempest variance, garden variance, Tempest TMB, garden TMB, and are they actionable mutations? Are they not actionable? And what's the immune landscape? Are these tumors immunologically hot or
Yeah.
how do they? And then is the hot tumor more likely to be heterogeneous tumor? All that landscape description with Tempest and Gardens. I think we're still going to pursue that.
Yeah.
But yeah, I think you need more time to get to the Tempest data.
Right.
So I don't think that should be our focus. But I think for ASCO, you can do the EGFR story. I just wish it would be more than 8 at like a double digit.
Right.
It doesn't have to be guarded based. Like if there's a way for you to figure out, more EGFR patients. I don't.
Right. Because the reason that the way we did it is we had GARD patients, then we screened all of them and we had a list of those who were treatment naive. And then when we screened that list, that's where we were able to identify some that received only EGFR therapy. And that's where these 8 came from. So we could look at patients who weren't treatment naive, but I think that kind of muddies it a little bit, or a skeptic might say, well, this doesn't mean anything.
So for people who are not treatment naive and EGFR positive, I mean, what's going to be different? Because we're only gonna just retrospectively look at their treatment history and and see how long they were on each treatment.
Right.
So I think whether they are treatment naive or not, we can use the same data set to screen for people who have tumors harboring EGFR mutations. And
that's where the issue is. So we have their clinical course, but the Tempest or the Garden data point is after they've already received that first therapy. So we don't know what mutation they had before they received the therapy.
Yeah. No, I understand that, but I think so it's either one. Well, so let's say EGFR classic mutation was there, and if they're on the right appropriate therapy, that clone sometimes disappears, it becomes non. And then there could be emergence of subclonal mutation, which is T790M mutation.
Yeah.
So if we treat that as like, oh, we didn't do the baseline, but we have one with T790M, that actually may be predictive of short response too. But if it's if you know, for acquired resistance, I think we might be saying that, you know, it might be acquired after 20 months. You know what I mean? So that's one example. However, I do think in many cases, the truncal mutation may still be present, and that might tell us, you know, whether you know, like the same correlation that we want to show. So
Yeah.
Or we, you know, for patients, people who are not treatment naive, could be may not show the good correlation that we've seen with the treatment
Right.
naive, and then that might be the another point to convey that on treatment liquid biopsy is not a good representation. Or something. So the bottom line is, I think it's still worth looking at a non-treatment naive group and kind of look at the same relationship you found with 8 patients. And if you do find good correlation there as well, just lump them together and present. If you don't find it, just say, you know, with on treatment patients, you did not find such patient, and this means such and such, right?
So yeah.
So I think you could add those additional patients and still write something up like application of in silico, not in silico, this is in vitro mutation to response as platform in real world, or something, like make it fancy. And then you, in the method, you said you utilize the platform presented by this group, and we you know, we looked at our own clinic data to see if the data is predictive of you know, real world response. And you can describe like 8 patients, what their mutations are, and the response group, you know, had mean treatment time of such and such, and their response were, you know, predictive of refractoriness, you know, with such inhibitor. And you know, you can kind of, you know, it's all descriptive, but I think
Right.
it's you know, it can fill up the whole abstract, you know.
Oh yeah. Yeah. I'm just worried that it might not be interesting enough, or like, you know, what would the title be, you know?
No, that was the title. The application of in vitro in vitro
Model or in vitro?
model in vitro prediction model for rare, well, so not rare, EGFR mutation subtypes to various EGFR TKIs in real world something
We
like,
should also probably say that this is liquid biopsy,
right,
because I think that's novel. I think that this has only been validated using tissue.
yeah. So real world data in real world data,
Liquid biopsy data.
real world liquid biopsy data. Yeah,
Okay.
real world.
So application of in vitro prediction model for EGFR subtypes to various EGFR TKIs in real world liquid biopsy data.
In real world clinic utilizing
Utilizing liquid
liquid
biopsy data.
biopsy. Yeah, liquid biopsy assay. Real
Assay.
yeah, assay.
Um,
Yeah, in
Now,
vitro
yeah.
it was a cell line, right? In vitro,
yeah,
you want in vitro cell line model or something.
okay. Cell line model. Regarding, again, to confirm, regarding patients that were not naive.
So I want you to do the same now, same analysis you've done for 8 patients. And if you find similar pattern, just lump them together. If you don't find the same, just describe them separately and say that on treatment is, did not show good correlation or did not predict. Perhaps because of the fact that the treatment is already influencing in liquid biopsy world, the treatment on treatment assays are already affected by the treatment, and so the clones are not
Going away, they're there.
yeah, did not not represented, or the whatever, yeah. So describe the difference.
What, I guess I'm just a little confused. So we'll have the treatment time for the first therapy, but the Tempest, or sorry, the Garden data point will happen, it might happen a year later or 2 years later. So if I see a mutation
Mhm.
there that isn't concordant or doesn't match that first therapy, that's the lot you're suggesting to say, well, it's here, so clearly it didn't work, or clearly the therapy that was chosen initially was not appropriate, or what's, I don't quite understand, because you can make the argument that even if the therapy was appropriate in the beginning, you can still develop new mutations that weren't present when the
So
therapy was chosen.
so I would go, like in the Epic, you can click pathology
Yeah.
and the initial biopsy of the tumor. Usually they do in-house EGFR sequencing.
Oh, really?
Yeah.
Okay.
So if
All
you
right. I didn't know that.
EGFR in Garden, just look for, and then also some people would have foundation or Tempest still. You might just be missing it.
Okay.
So I would still look at the tissue. So you go to Epic, there's you look at this under the media tab, you can look at all the scan document, and some of them could be outsourced path report, like NGS reports, Tempest Foundation. So you can look for EGFR there, as well as if you click the pathology under path, there's NGS, or there's sometimes PCR.
So, okay. So for the non-naive patients in the abstract, we'll say that what, I guess for them, the source of the EGFR mutation data won't be liquid biopsy.
I mean, that's how you screened it. You're gonna have to screen the non-naive EGFR patient first. So it is found there, but we also wanted to you could say in the method that on treatment, liquid biopsy patients were all confirmed to have, EGFR mutation, present at the first diagnosis of at the first tissue biopsy done for diagnosis or something,
Okay.
so that it's not something that popped up later on treatment. It was a EGFR was there, that clone was there from the beginning.
Okay.
And I think that would be the most case with those patients. I may be wrong, but that's how you kind of get away with,
Right.
in the first place.
So I just filtered the data set based on naive or not, like it doesn't matter if they were naive. And I have 14.
Yeah, that's a decent number to begin with.
And their treatment times range from 2 months all the way to 33 months.
Hmm.
And there's 2 patients here who received some chemo as well,
Hmm.
which we can lump those in the group as well. But
So let's do this. I know we don't have much time. Do you have to be in class today, or do you have time?
no, I have time today, so I can definitely go through, the additional 6 patients that.
Yeah. How about you divide and conquer? Maybe Eugene O. I know Sungmi is helping with the other. So maybe work with, maybe give.
It's really not that bad. Doing screening 6 patients shouldn't take me very long.
No, I
like-
want Eugene O to validate some, like make sure there's
Oh,
no
okay.
error,
Yeah.
and because she's medical doctor, and I just want a second eye.
Yeah,
So
absolutely.
whatever you're looking at and patient records and so have her double check, and she can revise whatever you wrote to make sure it's read better, more smoothly. Or so whatever you guys create a Google Doc and write it, Eugene, you help in the writing process as well as double checking the data. Yeah, let's work on those patients, and you get the whole idea. Like if you look
Yeah.
at, it's applicable in the real world. And I mean, the best outcome is usually the progression-free survival, right? But because that's what we usually use. So time to progression is a better terminology than treatment duration. But so the thing is, we want to differentiate if patients on treatment for only 1 month because of toxicity. That's not a parameter
Right.
we want to look at. So people distinguish time to discontinuation of treatment
Yeah.
to time to progression. So if you can do time to progression, that's better. But for if let's say if you out of all that, maybe that 20 patients in total, you only have 2 patients that osimertinib has to be stopped due to toxicity, then you just 2 patients actually had to be off treatment due to toxicity, not due to this disease progression. So they were not included in the analysis or something, like, because there's no way to measure,
Right.
right?
But for those patients, we can look to see what therapy they were given next.
Yeah.
And then that could be kind of,
Yeah.
that treatment time can be combined.
Yes. Yes.
So
Yeah, like the osimertinib, then I moved on to afatinib, things like that. Then you just to say that was discontinued and then the afatinib was used,
right.
So I think abstract purpose, if you extract the toxicity discontinuation and just make it so that, if I say in my note I will discontinue, it's usually because the CT scan show that it's, there's new progression.
Yeah.
So you could still say due to clinical progression. You don't have to measure resist. The fact that I discontinued based on CT just means that it's progression, and you can still use the progression-free survival.
Okay.
So let's just clarify that, and yeah, just make sure you actually look at the cause of discontinuation and find out it's not toxicity, and that's good enough.
Okay. So what I can do after this meeting is I can make a Google Doc with all 14 of these patients.
Mhm.
I can include their MRNs
Uh-huh.
and the data that we already have.
Mhm.
the clinical data. And then I guess Eugene and I can split those in half and just go through them
Yeah,
to confirm.
yeah.
Sure.
And then we can go from there.
Mhm.
So
Eugene-
I also have an SOP that
uh,
that
Eugene's email is here. You guys can communicate and
I'll let him know my.
yeah. And Stas, you can leave your phone number so that if there's any, because the deadline's today, if anything,
right.
Eugene can just call you right away. Just leave your cell phone number here so that she can call you.
And then I'll also add my email. So I also have an SOP that was made a few months ago, no, last year, about describing, some of the definitions we used and how we approached it. So I'll share that as well. Okay, great. Yeah, Eugene, I'll send you something after this meeting, maybe in like 30 minutes, an hour.
And then when you guys have like the first draft, just have Eugene print it and show it to me, then I'll revise it.
Okay.
And then Eugene can,
Yes, and send that back to Stas.
talk to you and you can submit it. Yeah,
Okay.
I think it's totally doable. And like going back to the Tempest data and the it doesn't have to be guarded. You could just explore Tempest data and the variance heterogeneity within Tempest and all the
Yeah.
landscape thing.
Yeah.
Shoot for a world long. That's due in 3 weeks.
Okay.
So yeah, that heterogeneity, the whole landscape thing, regardless of garden, we could just focus on tissue.
Yeah.
And yeah. So
So I'll pull all the patients I have Tempest for. I'll
Yeah.
also try to get more, and then I'll just go through all of them and get some kind of
landscape data. Yeah.
landscape data. I'll probably just focus on the first treatment time, or time to progression of that first treatment, just because it's easier to screen for than their entire treatment course.
Yeah. So you don't have, I mean, or the overall survival, or first treatment.
But doesn't that depend on the treatment they receive? So like if they, I feel like it's harder to control for multiple treatments, which you'd have to do if you're looking at overall survival versus on treatment time for just that first treatment.
Yeah.
I don't know, just as far as like screening and kind of the robustness of the data set.
Yeah.
I don't know.
For actual manuscript and study, people always ask for both first treatment, progression-free survival time. So on treatment time is not the terminology we're looking for. It's progression-free survival and overall survival. So it's better to collect both if we can. If due to time limitation, we can choose either one.
Right.
But if you can do, so even without those two, it's still going to be publishable, the landscape. Okay.
Yeah.
Maybe PFS and OS, there won't be much association because they all got different treatment.
Yeah.
Factors that that will lead to difference in treatment outcome. So so if you can get PFS or OS, great. If you can't, still okay to present the landscape itself. This is the mutation we see. This is the variant we saw. What's the relationship between the ITH variance, TMB, immune score? What do we see? And Tempest, everyone has HLA too.
All right.
Yeah, so there's a lot of things we can look into. There's PDL1, there's, all this, um, but and then you can look at, well, did ITH group actually live longer, or not? Heterogeneous tumor may do or may not do better with any treatment. That then it can affect overall survival. And overall survival is easy. When did they die? And then it's much easier than PFS. Like you did,
Yeah.
So yeah, with this in mind, maybe work on that data for next, a week or two. But for today, let's I actually like the EGFR in vitro data validation thing.
Okay. Okay. Yeah, I'll focus on that today, and then once we get that done, I'll switch to Tempest and see what the screening for that looks like. And we'll go from there.
Great, great. Anything else?
Nope, that's it.
All right, good. I think we can get it done. So
Yeah.
okay. Sumi, do you have any updates?
Yeah, I do have some updates.
Oh, it's echoing.
내가 손을 띄까? Yeah, sorry. I do have some updates. Can you hear me?
Yeah.
Yeah, so I'll screen share using Dr. Che's account. And so my two updates will be, one is what Dr. Liam mentioned earlier on. 근데 just wait, sorry. 근데 왜 안 들리지 않아? 왜 안 들리지? Sorry, we're in the same room, so we're having problems with the sound system. It's gonna take 1 second.
Hear you well.
Can you hear me now?
Yes.
이제 너가 안 들리지? 아니 이게 그냥 핸드폰으로 했는데도 안 돼.
Basically, yeah, there's two things that I want to share with you. Number one is what Dr. Leah mentioned earlier about how I could share information about the patients who are possible candidates for the interview. And so I just want to quickly show, just to confirm if this is the kind of format that would be good for the undergraduates. So
Oh, before I forget, stats, we're gonna recruit pacemaker, volunteers. So once you get contacted by, Dr. Liso Kim and, yeah, try to, post it in a, online bulletin or somewhere where you could talk to people. You could,
Yeah, what I can do is if you guys give me like a blurb about pacemakers, I
Yeah.
can send it out to to all 4 med school classes. There's like an email listserv that I can send it to.
Yeah. Oh yeah, and then I don't know if it was you or Yuji. Look, let us know what is a way to register this, like chapter or pacemaker chapter, Feinberg chapter or something, like make it as like a formal student group.
Yeah, that's definitely doable. I mean, I think it just requires submitting some paperwork and having a faculty and sponsor, which would be you. So I think it's totally doable.
I'll just log in with this.
You'll just need to find
I think I'll just log in with
kind
this
of-
one. 그럼 너도 들릴 수
You just
있을
have
것
to
같아.
you have to set up kind of a
어떻게 볼
a
수
board,
있나?
people to manage it.
나가고.
Usually, it needs like, I don't know, 4 people, 5 people. Each person takes on a different role.
Okay.
So that's kind of it.
Into it and maybe draft whatever, just like, to just make it a formal group before we actually
Advertise.
a bit, yeah, advertised because I want this to be more formal before.
Right.
Yeah.
I just don't know what the time frame is.
Mhm.
There might be some requirements about, only new groups can only be started in the fall or something like that. So we might
Yeah.
have to wait till the fall to get it started.
So
But
just look into it and let me know,
yeah,
next meeting what you found and what are the forms, and if it's easy enough, you can just fill my name and your name and Eugene, Kim, and Samantha and whoever, like
yeah,
yeah, it's all formality. Yeah.
yeah. Okay. Yeah, I'll look into it and give you an update next week.
Okay. Thank you.
Definitely. Mhm.
Yeah, so basically this is just, I'll just continue making the list. You could search using these names, they're searchable. These are the comments you mentioned, like small things. I didn't write the phone number because it's personal information. You could search it using these names. And so this is like a version that's, I think if you don't have medical knowledge, you can still read it, but it's still detailed enough for you to get an idea of the patient, because the patient will be, they might bring up like metastasis or something. So I did want to make it detailed enough. So yeah, so I'll just read this paragraph. So he went to the PCP for these symptoms, and then he had anomalies in the CT chest scan, and then these are the medical terms, which I explained, saying that what it means, and then how these anomalies increase, and then it just goes on to tell you what kind of treatment he received, and yeah, and that goes on for the other patients, and I'll do with this patient as well. And I just thought of some sample questions myself, but I just wanted the undergraduates to think of an answer themselves. So I just thought of a few which we could ask for the interview. Like, when do you feel most encouraged, or what was most frustrating for you? How did your relationship with your healthcare providers develop over time? Things like these. And I also definitely think there should be an open question. Um, you know, so that the patient themselves could answer their own choice of a question.
Mm.
And then the other thing I did wanted to share is the
Oh, before you go, so
Yeah.
I think Liam and Grace can chime in and add the questions that were relevant for your, pacemaker movement abstracts. So maybe, yeah, you guys can develop sample questions with Sungmi as well. And I think it might be good to start with, can you describe your treatment, cancer treatment? Can you briefly summarize your cancer treatment journey? And that's like open-ended question. Delma said, "Oh, I was diagnosed with lung cancer 5 years ago, and I underwent many treatment, most of which were not really successful. And then now I'm on this therapy. So yeah, I think that's a good starting question. Uh, yeah, and then the key is, how would you describe your relationship with your, healthcare provider, or maybe the better term is your care team, or your doctor and and your doctor and your nurses. And how did that relationship impact your care? That's a good way to like all open-ended questions, yeah. And and then you can word it differently by each. And I think a good practice would be, and Liam, this is for you too, we can put like this is we want to the flow is how did you get treatment and how did the doctor patient relationship affect and how did and did you feel were how were like being encouraged and then just maybe can you talk about the importance of um, empathy or encouragement, or something like I think should be a question asking about the philosophy, or what was the greatest lesson that you learned during your cancer treatment journey or something like that. You could be and then let's say forgot. Oh, so do you have any word of advice for future healthcare professionals or something like and then there's this be nice, be kind, they treat your patient like your mom. They might have something to say, and then also, do you have any word of advice for your fellow patients, people who are suffering with similar diseases? Do you have any word of advice for them? Yeah, those are all good things. So now I get it. So let's say we make like 20 lists of questions and we actually send those questions before, like through email.
Oh, yeah.
So the patient can think about
Mm.
those answers a day or two beforehand, and then they can actually choose like, oh, I actually want to answer like 6 out of 20 questions or something. Give them a choice, so that way they come very prepared.
Mm.
They make them choose questions, but I think we can at least give them these 2 questions we always want to ask them, like describe your cancer treatment journey. This would be all different from every for all interviewees, and then what any last words or advice for healthcare professionals. I think that's the key, because our audience is not just patients, but we want to educate our fellow healthcare professionals. So remember, our audience is trained medical students and doctors to become pacemakers. Yeah. So I think that's a good start. Okay, great, thank you. We can move on.
The other one is this project. So the role of ctDNA in monitoring non-cancer patients who went through curative treatments and seeing the landscape of ctDNA and in assessing minimal residual disease. So I'm very new to this kind of research. And this is the raw data. And Eugene told me that these are some of the things I could focus on. And then I copied, as per Dr. Che's advice, from I think Dr. Yuno's criteria. And I tried with one patient, like filling it out. But I wanted to just check these criteria with you because it's a lot and it's from a research that focused on the radiographics or something. So I may not need all the criteria. So I thought maybe you could help me just, put down some.
Sure. So
Yeah.
show me
So,
each
mhm.
variable. So you need
So,
you need PDL1, you need PDL1 in tumor, you need one in immune cell. MSI high, you don't need because in lung cancer, it's always stable. TMB, I think you need the raw data, yes. So you could do TMB raw data. And sex, smoking, I would get staging, I would get, and then the mutation, I would get everything. TTF1, I would get.
yeah, yeah.
Neoantigen, if they have Tempus, you have neoantigen. Okay,
Oh, okay.
Tempus, but you have to go to the Tempus portal website to get the number. Berry strat, I would get total immune infiltration that you can get from Tempus. All that immune composition you can get from Tempus.
I think these are good.
Yeah, because we don't have, well, you can so NLR and platelet you don't need for this. This is it. And metastatic site you don't need because we're not dealing with metastatic disease here.
So all these
Are
include-
not needed. Index treatment type. Yeah, so you need, did patient receive neoadjuvant chemo or adjuvant chemo? Did patient receive neoadjuvant radiation or concurrent radiation? So you have to write down what treatment patient received and date of surgery and what surgery patient got. Lobectomy, segmentectomy, or was it concurrent chemo radiation? So you have to write the date of curative treatment. So date of progression only pertains to metastatic disease. Again, we're not looking at metastatic disease. So date of recurrence is the right term. But I think most of our patients did not recur because we have a very short follow-up time. So that's not the primary endpoint of this research. The purpose of this research is to describe the landscape of ctDNA minimal residual disease in patient who underwent curative treatment, meaning what was positive before surgery, what was positive after surgery, what were the mutations, what were the most common mutations that were found, and was there any correlation with TMB, PDL1, histology, squamous versus adenocarcinoma, or location of the tumor, or surgery versus concurrent chemoradiation, male versus female, smoker versus non-smoker. So you can look at all different association within the landscape study. So this is very different than the usual study. Oh, MRD is positive, so they are likely to recur. So the limitation of the study is we don't have that length of follow-up yet. So we don't have the patient who actually recurred.
Yeah.
So we're not looking at the outcome. The predictability of MRD assay is not the endpoint. So we're doing this to see if there's any clinical pathological correlation to pre and post MRD assay results. More like a longitudinal study. Okay. Okay. So I think you have all you need.
I have a couple of more questions regarding this. I was wondering what these are, upcoming works. I don't think I need them, right? These are,
No, I don't know what they are.
yeah. And just a couple more really quickly. So here they use age of diagnosis, but should I do the date of initial diagnosis, or does it matter? I don't think it matters.
So you need age. Well, age should be coming from age at the time of, let's do it at the time of surgery. So, well, you don't have to use the term surgery, but you always use the term curative treatment because you're looking at both surgery or concurrent chemoradiation, which is also curative. So age at the time of concurrent, at the time of curative treatment is what you want. But also collect the date of curative treatment, just to, for clarification.
Sorry, one other thing, in Guardian and Tempest, the TMB was, sometimes the figures were different. Which one should I stick to, or should I just write both for now?
So if you have Garden, use Garden TMB as well as TMB. So use both.
Oh, so I'll write both in two different categories.
Yes.
Just a few more things. Cancer staging, I don't know why, but 3C is not here, the one used. So should I write like just the cancer staging like this, like in Roman letters, numbers, or because I can number them later on. That's not a difficult. Which one should I?
The better way to record would be stage, end stage. M should be 0 because if you have M1, you're not going to get curative treatment. You're going to get palliative treatment. So you don't need M, right? T stage and N stage, and then the T and M staging, which would be, stage 1, 2, 3. And you can be specific as to 1A or 3C. You could, you can do that.
Yeah, we're almost done.
Some are not clear by looking at the Epic notes. Then you would just look at the CT scan and go by the rules. And if it's not written in the note, you should just figure out what's most appropriate.
Yeah.
It's usually staged at diagnosis.
And just a couple more. So these are the ones, but sometimes you get like HER2 in the results. So, but should I add that in as a criteria or not? For lung cancer, would it be needed?
So I would have one variable, say other mutations, and just more like a qualitatively, what are other mutations that were found? And only put not the VUSs, but only the actionable mutations. So HER2.
Oh, sorry. So yeah, the other VUSs, I could ignore them.
You can ignore VUSs.
Yeah, and I'm almost done, but should I keep these criteria about death? Like when none of them died, I think, but should I just keep them here for future purposes? I don't know, there's all these other stuff, but should I just if there is information, should I just add it on?
Yes, you leave progression-free survival, recurrence-free survival, and overall survival. So date of death, date of recurrence. Because I want someone who comes to our lab 2 years later to collect survival and recurrence so that we could look at these later on. So yes, keep them. Although for your data, it will be all everyone's alive, everyone's recurrence free at this point, or something like that. Maybe there's one patient who recurred. I don't know, but we have to look at the data.
This is not needed for me, but like for this one, I did understand like for this one here, brain metastasis before treatment. So if there was progress, I feel like
So that those
it's
are
a
all
very
metastatic disease, and you're not looking
oh
at metastatic disease, so everything is not relevant for you.
okay. Yeah, and that's I don't know why these are here, but I should ignore them, right? I
Those
just was wondering the significance of
Those are relevant variables for prognostication. But for MRD recurrence, I don't think it's related, so you can ignore those.
okay. And final question. So I'm just so there's like 100 patients. I'm trying to get them done by tomorrow. And then do you recommend can you give me like something else I could start on after I make this chart?
Well, you have to write an abstract.
Oh, can you be a bit more specific in how how I should start writing abstract after I gather this data? Should I try analyzing it
Yeah,
first?
you have to first analyze and find the trend. And if you need help, you present during the lab meeting and we discuss as we are doing with any other projects.
Okay.
We troubleshoot together during lab meeting and
Mhm.
find meaning out of each analysis, and decide on what to write. And that's what we did with Stas today. So
Okay. Thank you.
great, great. So how to analyze, how to do the landscape? Read a lot of similar papers. Okay, how did they present their data? How did they make tables? What kind of clinical variables did they do correlation study with?
Yeah.
All in the articles. Okay, so
Okay.
learn from the most recently published articles on the same topic. And you should always have a mindset, oh, they looked at these and these and these, but they didn't really look at this. So this is my niche. Okay, what am I gonna show to the world that other people have not shown? Strat and hyperprogression. No one has published anything about that. Okay, so Dr. Yuno is published, presenting it, right? Liquid biopsy and in vitro prediction model. No one actually looked at the real world data, so it's still worth publishing.
Yeah.
So I think yes, Signatera has been approved in colorectal world, but Signatera has not really been used in lung cancer world much. Okay, what is the real world data of tissue 16 gene tissue based assay of liquid biopsy, and what's the landscape, who and what are, oh yeah, and then you have to write down all the genes. What were the genes that were found from Altera and Signatera? Remember there's Altera, and if you don't have the Altera results, email the Signatera, Natera people and ask me. If you don't have the contact, ask me. Okay, email them. I think Eugene is CC'd on Natera emails, and ask them like, can you send us the Natera result? So Altera is tissue, Signatera is liquid.
Okay.
Okay, so
Yeah.
compare what was found in Signatera and how many genes were actually found and what were their BAFs. before surgery and after surgery, did the VAF change over time? And if not all of them will have pre-surgery Signatera, but just with the ones that have pre-surgery Signatera, what were their BAFs? And then post was it and after surgery did it all disappear? Now, one other interesting thing that you could compare, and this was never been looked at before, is compare Signatera result with Guardant. And this was only done with Albert Curie's data. So what's interesting is Albert Curie had lung transplant. So in theory, his Guardant should be non-detectable, but was detectable. How do you explain that when Signatera has been double negative after transplant? So we know that some ctDNAs detected after surgery are coming from non-cancer lesions, like adenoma from colon polyp, aortic aneurysm, they shed ctDNA, okay? The most famous source is fetus, okay? So that's called prenatal Down syndrome screening is done through circulating DNA. So it's not ctDNA, it's cfDNA, free circulating DNA. So that's a nice discussion for your paper. It's not always tumor. You can have non-tumor source of circulating DNAs. That's why I favor Signatera approach rather than Guardant, because Guardant never compares to tissue. But Signatera picks up 16 unique genes from tumor, tissue, and then creates a unique panel, individualized panel. So the panel is, everyone's panel is different because that 16 gene is different from every patient. That's their approach. That's what we read in my JTL review paper. Anyway, that's why you have to describe all the genes and what are the most frequently mutated genes. What are that 16 gene panel? What are the most commonly used mutations to create that panel? P53, as we expect, or is EGFR included there? So that genomic landscape is very important. And so some of the, not everybody, some of them will have pre-surgery Guardant, and you can compare Guardant and Altera and describe the difference. But Albert Curie might be the only one that has actually Guardant after surgery. Let's see. Tissue. No, I think that's good enough.
Yep. It's a lot to think about, and thank you so much. I'll be like working on it for sure.
Yeah. Yeah, deadline's coming soon, so
Yeah.
work on creating preliminary data.
Mhm.
All right. Okay. Anything else from any of you guys before we wrap up?
Can I say?
Yeah.
So I'm still working on the protocol project.
Yeah. Protocol.
So can you give any input of that? I know the time has spent so much today, but can I share?
Yeah.
Okay. Yeah. So can everybody see the screen?
Yeah.
Yep. So first of all, I revised the title like this, and I remember.
What's that?
Sorry, I can't hear you.
I think you should do something about. To me, I think you should turn off the speaker.
Yeah. I think title we can just come back later, and I want to just
Take
add.
out the studies: perspective, observational, registration study.
Oh yeah, sure. And I'll just briefly mention the changes I've made so far. So I revised the objectives like this. So primary outcome including 30-day mortality, survivor, recurrence, and rejection rate, and secondary outcome including the quality of life and comparison with historical data of non-cancer lung transplantation, including long-term follow-up and recurrence and rejection rate either as well. And thirdly, lastly, molecular and genetic biomarkers, including MRD and genomic profiling of cancer. Would those be enough?
So,
Yeah.
so it's not confined to genetic. So just say more broadly. So the objective should be primary objective, secondary outcome, primary. Primary objective. Secondary outcome. I would say primary objective, and then you have to write out the sentence to assess the 30 is to assess. No, yeah, this has to be separate. Yeah, to the takeout it is this.
Okay, just
yeah,
got it.
To assess 30-day rejection rates. Secondary objective, same thing, to assess quality of life.
Okay. Yeah, I think I can.
To assess quality of life metrics.
Chris, sorry, could you repeat?
To assess quality of life metrics.
Oh, okay. So I searched the paper on quality of life measurement of patients for whom the lung transplantation was done for BOS, and they used pretty much a lot of different kind of questionnaires.
Yeah.
So I just wrote them down all, but maybe I could just select some for our protocol. And
Yeah. So that don't have to be depression or coping. It could be
just the first one, or
yeah. So choose the one that is the shortest and most convenient,
okay,
most quantifiable, um, and most commonly used. Whatever, yeah, it's fine.
okay,
And then number three, a second to assess, well, secondary objective, and then put number one, number to assess.
okay,
Yeah, in number two is to
compare.
uh, prognosis. Compare the outcome data with
Yep.
yeah. And then large number three would be exploratory objective. And put in the parenthesis translational medicine.
Okay. Translation and
Medicine.
Okay.
And this is to explore markers, including interpret. And then put at the end that uh, may correlate with outcome. Yeah. Yeah, that's good enough.
Okay, thank you.
12.
Yeah.
Yeah.
Yeah, starting from 12 and
Maybe change, maybe 20. Maybe put 20.
okay. Mm-hmm. And it consists of the introduction and then study objective. I think I can just copy from the above, and then it goes on to inclusion criteria and exclusion criteria, and then moves on to study registration and design and methods. And it's my first time to actually work on a protocol. So
Yeah. So the JAMA
uh-huh.
paper that I share the link, that would be a good paper to use as a reference.
Okay.
And it talks about the transplant itself, how it was done, all that. So yeah.
I'll reference that, and then because I'm not done with the introduction part, so could you just look at the paragraph composition that I just make up and give any input?
Yeah. So IMA.
I think I was too focused on the IMA because we're gonna select it. We're gonna include other patients other than IMA. So
Right. So remember the NEJM paper?
mhm. Yeah, right.
So it's a similar criteria.
I will revise this version based on the NEJM and JAMA paper. And then I think
Yeah, so take out the mucinous part and just make it, whether it's mucinous or non-mucinous, they will be eligible. So I
mm,
think your focus has to be there somehow. There's a subgroup of lung cancer that really does not show any distant mets. And
okay.
people die of just the lung disease. And for this people, and here, once we get the abstract selected for world lung, you should cite that abstract, and our group has performed the site, lung transplant for invasive mucinous, and patient still alive, doing well with
Yeah,
minimal residual disease. So you can still describe that, and then in the parenthesis, not published. And once it's published, you can cite the abstract. So I would add Albert Curie's case in the introduction.
okay. Okay, and then could you just look at the selection part? So basically,
Say, based on the WHO classification, is it eighth
yeah, 8.
edition?
Should I remark that? Like,
And then I would say 7th edition bronchial alveolar carcinoma is because some old schooler pathologists still use that terminology, although it's now.
yeah, now it's the testing, but I will mention that.
But it should be a separate criteria for yeah, for bronchial alveolar carcinoma as defined by the 8th version will also be included for the trial, or something like that, just like as a footnote. Yeah, something like that. So I told you this, new diagnosis, previously treated any number of lines are acceptable. This is wrong. So you have to be resistant or refractory to standard of care systemic therapies, and also resistant or refractory to experimental therapies when clinical trial options are available. So that's the right terminology.
Okay.
Let's say if there's a really good clinical trial, you should try that first before going to the transplant. You know,
Okay.
the message we want to get across. And obviously, patient has to be on lifelong immune suppression, right? You don't want them to have significant suppressive disease, like HIV or things like that. So the general criteria for transplant should be applied here.
Yeah, so I mentioned that actually in the exclusion criteria area.
Oh, okay.
And I just looked up for the lung transplantation guidelines for like kind of lung disease, but there were none for cancer, definitely lung cancer. So I found out guidelines for COPD or cystic fibrosis or like bronchiolitis, anything else. So do you think I should put all of this kind of relevant numbers in here?
No.
Okay. So I just mentioned like there should be no involvement of lymph nodes and distant metastasis. And I mentioned good general health And for psychological thing, I just mentioned this. The patient should undergo psychological evaluation using, I found this SIPAT as a standardized tool that we can use. Do you think it should be also here, or can we remove this?
No, I think it's okay.
Okay.
No, I don't using, I would take out the using.
Uh-huh.
Just put in the parenthesis that
Um,
can be used or something. So that it's optional.
oh yeah, sure. Then for exclusion criteria, I made it based on the general rules regarding just lung transplantation. But I think this could be too exclusive, maybe, or not. So
65.
yeah, I found this in this reference article.
Okay. Let's do 70. Okay. It's okay.
Okay. Yep. So I'm working on based on the thing you sent to me, the previous like protocol
Yeah.
for biomarker.
Yeah.
So yeah, I will work on more and then show you next week.
Sounds good. So let's open this trial ASAP.
Oh, can we open this like right after I finish this one, or are there more steps like IRB thing or?
No, we have to get this approved by our, so there should be a, plan for analysis and plan for de-identification and,
Oh, more.
all that things should be there.
Okay.
Plan for publication. Yeah.
Yep. Okay.
Okay. Good job. So, and Liam can help with editing whatever you wrote. So,
Okay. I'll ask him.
okay. Very good. We'll see you guys next week. And Stats will finish your abstract today. All right. Take care.
Take care. Thank
Bye.
you. One. Oh. Oh. Says it
Yeah.
works.
Yeah, it works.